Hello from San Francisco. My name is Rolf-Markus Szeimies. I'm professor and chairman of the Department of Dermatology and Allergology in Recklinghausen, and I am reporting from the American Academy annual meeting, the 73rd annual meeting here in San Francisco, and I'm trying to give you an impression of interesting talks over the period of the whole meeting. So today on Friday I want to start with the meeting I attended, which was from Professor Paola Pasquali from Tarragona in Spain, and she gave us an interesting update on cryosurgery in her talk. Cryosurgery has been used for years in dermatology, and mostly we use it for the destruction of tumors. And there are nice new concepts which are presently discussed, and she mentioned the idea of cryoimmunology. So we not only freeze a lesion, but the tumor remains in situ after the cryosurgical procedure. And there is then a release of tumoral antigens, and those antigens induce an antitumoral response by inflammation. So we have a double shot sort of mechanism how to destroy tumors when we treat tumors with cryosurgery. So this is a very interesting technique, and you also can use different techniques for the whole procedure. We have open or spray techniques, as she presented. You can also use a semi-open approach or a cone technique. There is a close or probe technique also possible, and you can even use chambers or a semi-close technique, especially for larger tumors. She also introduced what was also new to me, tweezers, which can be cooled and then directly compress small lesions like filiform warts or fibromas, which is very convenient with this approach. And you also can perform intralesional therapy with a cryosonde. So the question is, do we need pre-treatment for our lesions? And there is the possibility, especially for lentigo, that you do some retinoic acid or glycolic acid prior to the treatment with spray, so the open procedures of cryosurgery. You can also treat other ideas like the varicose warts, and in these cases it's very important that you get rid of keratin, because hyperkeratotic crusts are relatively thermal resistant. So in order to get a good result, it's very important to remove the crust first before you perform cryosurgery. And she took very important notice on this fact and said that the response rates are getting much better when you use debriding agents prior to the treatment with cryosurgery. An interesting approach is also a so-called cryobiopsy, and she recently published in the JAD a report on that. And that means that you freeze a lesion and then you cut the lesion and directly put it into histology, so that there is no bleeding overall because the whole process is already frozen. So a very easy and convenient form of getting a specimen for histology. And the process of freezing does not mean that you really induce a damage to the tissue so that the pathologist is not able to study this material. So that is really not a problem. Interesting is also what she reported on cryoanesthesia. The cooling process itself gives a very good anesthetic impulse, and that means that during this process the patient doesn't feel pain. The pain is derived from the thaw process, and even afterwards, when there is some inflammation, then the patient feels the pain. This easily can be used, for example, when you treat children with cryosurgical procedures, like patients with hemangiomas or granuloma pyogenicum. In these cases, she also gave the idea that the young kids should not be fed until the procedure, and then when she performed the procedure afterwards, the babies get immediately something to drink, and then they are so much satisfied by this that they don't feel the pain and they don't cry, which is good for the doctor, the nurses, and the mother who is attending the child to be treated. Also, cryotherapy can be used for treatment of actinic keratosis, and there normally one would say that this procedural approach by cryo only focuses on single lesions, and this is of course true, but also a sort of cryopeeling can be used for field cancerized areas. Of course, you then have to take into account that there could be some side effects for the patients. Another aspect of her talk was on combination treatments, and she talked about cryosurgery in combination with 5-FU. She mentioned a specific lacquer which can be used after the treatment of cryosurgery. You can also combine it with imiquimod. I will come later on that again. You can combine it with diclofenac sodium or with ingenol mebutet. And as you can see from the drug, so it's also focusing on actinic keratosis. Specific techniques were mentioned especially for approaches of treatment of large tumors. In this case, for example, the so-called segmental cryosurgery can be performed, which means that you divide a large area in different sub-fractions, and then you treat those individually. So overall you get a complete freezing of the tumor, but the result is then a very good one, instead of when you focus just on one point and wait until you get a complete freezing of the lesion. This is not a good approach. Another idea is the so-called fractional cryosurgery. That means you start in the center, and by going around with the freezing spot in a circular way, you then get a complete freezing of the whole lesion as well. Finally, as I said, the combination with imiquimod is interesting in respect of enhancing the effect of cryoimmunology. That means you start with imiquimod over a 5-week period, and then after 2 weeks you perform a cryo. And this ameliorates the result and enhances the effects of the cryo procedure, and you get better results in your patients. Of course, cryo has side effects, and in her final part of her talk, she focused on the immediate events we all know from cryo, so transient erythema, discomfort, of course, the pain, and especially edema, which is a constant phenomenon, especially when you treat areas around the eye. So patients can suffer severely from edema, and they should be noticed about this side effect prior to therapy. So bullous formations and the development of exudation is typically seen after 24 to 48 hours, and late events, of course, have prolonged healing processes, the postoperative redness, which has been mentioned, and also sorts of hyper and especially hypopigmentation, which could be disturbing in some cases, but it then also depends on how vigorously you perform your cryotherapy. So overall, and this were her final comments, I think, and I also believe it from my point, that cryosurgery is a very interesting tool in the dermatologic armamentarium of us dermatologists. Thank you very much.